everybody. Welcome to our Scleral Education Society webinar for the month of September. We'll have a lecture on Beyond the Ablation Zone, Optimizing Scleral Fits in Post-LASIK and Post-RK Corneas. But awesome guest speaker here. But before we go into her bio and intro, I want to give everyone about 30 more seconds to kind of keep milling into the room. Everyone's slowly trickling in. And I imagine we probably have people from all across the world here tonight, both US and maybe even some of your colleagues in India.
Yes.
So this Madhumathi is in India, and I'm not going to go into her bio too much here. I mean, it speaks for itself, that 20 years of experience, but she's going to share a little bit more in just a few minutes, going into a bit more detail with her mode of practice, which is amazing what they're doing at her hospital. The amount of patients they're helping and fitting, and very complicated cases, as we'll see today. She has no financial disclosures. Everyone who's done this before may know this, but use the Q&A feature for questions. Any questions you have throughout the lecture, go ahead and drop those into the Q&A. At the very end, we're going to reserve the last 10 minutes to just address all the questions at once. But as soon as you have a question, just drop that in and we will get to as many as possible. For those who need CE credit, you must remain online the full 50 minutes. You don't have to stay for Q&A, but I find that's kind of some of the really fun time of the lecture. If you have the app, at the very end, there'll be a QR code. That way it directly links to the OA tracker. If you don't, no worries. About 2 to 3 weeks from now, you'll get an email with your CE certificate. And without further ado, I'm going to stop sharing my screen and transfer over to you so you can kind of give your background and get going on this awesome lecture. Thanks for being with us tonight.
Oh, thank you. Thank you, Dr. Skidmore, for the kind introduction. So, good morning, good afternoon, and good evening to everyone joining across the world. First, I would like to thank the Scleral Education Society for giving me this opportunity to present today, and also my organization, Shankar Netralaya, for their constant support and encouragement. So, a brief about me. I am Madhumathi Subramanian, and I head the Department of Contact Lens at Shankar Netralaya, one of the leading eye care hospital in India. So it's truly a pleasure to be here among the fellow scleral lens practitioners, and the topic of my presentation is Beyond the Ablation Zone, Optimizing the Scleral Lens Fit in Post-LASIK and Post-RK Corneas. As we all know, refractive surgeries such as LASIK and radial keratotomy have transformed vision correction for millions of people worldwide. However, with time, many of these patients return with visual challenges, irregular corneas, high order aberrations, or even vision fluctuation. So this is where the scleral lens play a crucial role, not just in rehabilitating the vision, but also in restoring the comfort and enhancing the quality of life. So in this session, I'll be taking you through the unique challenges of fitting scleral lenses in surgically altered corneas, the strategies to achieve the optimal fit, and some clinical pearls drawn from the real world cases. So let's begin the journey beyond the ablation zone. I'll start with a quick introduction to refractive surgery, then move through the anatomical and optical considerations, diagnostic scleral lens fitting approach, clinical cases, and end with the practical take-home points. So I'm sure most of the practitioners here would agree that fitting contact lenses after refractive surgery can be particularly challenging, since the conventional designs are often unsuitable for oblate corneas. So many of these patients initially opted for surgery because of the contact lens intolerance. So when the vision issue arises later, they often return feeling frustrated. So in these situations, our responsibility goes beyond the technical fitting. It also includes offering a reassurance and psychological support. So before moving on to the scleral lenses, I'd like to briefly outline the characteristics of post-radial keratotomy and post-LASIK corneas and highlight the common challenges we face when fitting them with the regular contact lenses. Radial keratotomy or RK, which involves multiple radial incision to flatten the cornea. The main complications we see are under or overcorrection, often persisting years after the surgery, along with induced irregular astigmatism, anisometropia, and glare or halos from corneal scars. A key feature of RK is fluctuating vision during the day, usually more hyperopic in the morning and shifting towards myopia by evening due to the corneal instability and hydration changes. Over the time, many patients also develop progressive hyperopia and irregular astigmatism, making spectacle correction difficult and leaving the contact lenses, particularly scleral lenses, as the most effective solution. An important question is what? When can we fit contact lens after RK? The general guideline is to wait until both the refraction and the corneal topography are stable. This usually means a minimum of 3 months after the surgery. By this time, the peripheral corneal edema gets subsided, scars become more stable, and the risk of lens-related complications becomes lower. We also need to be cautious about prescribing extended wear or very long daily wearing Pars lenses because this can worsen the diurnal vision fluctuation that are already common in RK patients. So patience in timing the fitting is the key to better long-term outcomes. Post-RK corneas are mostly oblate and irregular, which makes rigid gas permeable lenses unstable. They tend to decenter, cause mid-peripheral bearing, discomfort, and patients, they often complain of glare and halos from the small optical zone. Soft lenses, piggybacks, and hybrid lenses, they don't really solve the problem. They either give a poor quality of vision, compromise the oxygen, or fail on highly irregular corneas. Moving on to the next procedure, LASIK, which is the most commonly performed refractive surgery worldwide. The procedure involves creating a corneal flap, ablating the stromal zone with an excimer laser, and replacing the flap. While LASIK offers faster recovery, less pain, and predictable results, especially in high myopia, it is not free of complications. So as you can see, the primary indications for fitting contact lenses after LASIK, it includes overcorrection, undercorrection, flap-related complications, irregular astigmatism, stromal haze or scarring, and in rare cases, post-LASIK ectasia. Topographically, LASIK corneas typically show a central flattening with a relatively steeper mid-periphery, giving an oblate contour. An interesting feature is the hinge effect. Areas which are close to the flap hinge tend to show flatter curvature and slightly elevation because of the flap retraction. So these factors definitely create optical challenges that makes the scleral lenses a strong option of visual rehabilitation in post-LASIK patients. So fitting contact lenses after LASIK presents unique challenges and timing is very, very critical. Soft lenses can be considered as an early option as to say 1 to 3 months post-surgery once refraction stabilizes, mainly for mild corrections. Rigid gas permeable lenses, while offering excellent optics, are best delayed until at least for 3 months after LASIK to ensure the corneal stability. Piggyback systems are usually reserved for cases where the GP lenses are not tolerated again after sufficient healing. So in practice, these limitations leave many patients with persistent issues such as glare, halos, unstable vision, and discomfort, especially in the presence of post-LASIK dryness. So let's see how we can successfully make the corneal health better and vision improved. The importance of scleral lens in post-refractive surgery is very well supported by the SCOPE study. According to this large international survey, scleral lenses were fitted in about 26% of regular corneas, but more frequently over 74% in irregular corneas. And what's most relevant to our discussion is that almost 70 of the practitioners reported fitting scleral lenses specifically for the post-refractive surgery cases. This clearly tells us that the scleral lenses are not just an alternative, but a preferred option in managing these complex and challenging eyes. So when to introduce scleral lenses are introduced once the stability is achieved at around 3 months or later, which provides a comprehensive solution. What happens? They vault over the entire cornea, mask the irregularity, reduce the higher order aberrations, and provide a large optical zone that minimizes the night vision problems. Most importantly, they deliver consistent comfort and vision throughout the day, making the most effective option for post-LASIK visual rehabilitation. So far we have reviewed the challenges of fitting soft lenses and GP lenses, as well as few advantages of the scleral lenses. Now let's take a closer look at the corneal contour and understand the key considerations for scleral lens fitting. So when fitting scleral lenses, we focus on three main criteria: the central and mid-peripheral vault, the limbal clearance, and the landing zone or the haptic alignment. So for the central vault, we measure the fluid reservoir thickness in microns. So the goal is about 200 to 350 microns initially, which can settle down to around 100 microns after several hours of wear. Importantly, we describe the vault as adequate, minimal, excessive, or touch, just by avoiding terms like steep or flat, which we use in GP lenses. Next is the limbal vault. It's very crucial that the lens clears the limbus fully throughout 360 degrees with around 80 to 100 microns of clearance in order to protect the delicate limbal stem cells. And finally, the landing zone fit, which should align with the sclera. If it's going to be too flat, we see an edge lift and bubbles. If it's going to be too steep, there's going to be blanching, compression, or impingement. So the ideal fit is one where the lens centers well, remains stable, and leaves the conjunctiva healthy even after extended wear. So let's now understand the oblate and prolate scleral lens design. Prolate scleral lenses have a steep corneal central curvature that flattens towards the periphery, making them well suited for naturally prolate or keratoconic eyes. However, in oblate corneas, such as those after LASIK, RK, or even certain flat grafts, also we use reverse geometry lenses where the central base curve is flatter than the adjacent peripheral curve, which is fitted, that creates fitting challenges. So what happens when a prolate lens is fitted on an oblate cornea? Now let's look at the problems we face using the prolate scleral lenses on the oblate cornea. So at first glance, the center clearance may appear adequate, but the real issue arises in the mid-periphery. Because of the mismatch in the shape, the lens tends to land or touch in the mid-peripheral region. So in order to compensate this peripheral touch, we are often forced to increase the overall sagittal height or vault of the lens. But when we try to do so, the side effect is excessive edge clearance, central clearance. So this excessive clearance has several important consequences. The first thing, it reduces the oxygen transmission to the cornea, especially to the central part, which can compromise the corneal physiology. Second, it can lead to the mechanical and optical instability, which cause the lens decentration and patient discomfort. Third, excessive clearance increases the likelihood of midday fogging due to the tear stagnation and debris accumulation. Finally, it can introduce optical issues like a prismatic effect and higher order aberrations, which reduces the overall quality of vision. So in summary, I would say, while it may be easy like a simple solution to increase the wall to clear this periphery, this approach comes at the cost of central physiology, comfort, and visual performance. So this is why the lens design must be very much carefully selected to match the corneal shape. Now let's look at why oblate scleral lenses are a better choice for the oblate corneas. So with an oblate design, we achieve the right balance, adequate mid-peripheral vault while maintaining the controlled central clearance. So this translates to a very much healthier fit because the lens centers well, better on the eye, the patient experiences improved comfort and stability. So the reduced clearance also means better oxygen delivery to the cornea, which is going to be very crucial for long-term corneal health. Another advantage is that larger optic zone, which helps minimize the glare and halos, especially important in post-refractive surgery patients. So since the oblate lenses require less minus power, the optical quality improves and we avoid the distortion seen with the thick and high minus designs. Finally, I would say the oblate scleral lenses provide stable vision even in challenging cases like decented ablations or ectasia, where a prolate design often tends to struggle. So overall, the oblate lenses offer a much more physiologically and optically favorable solution for these type of corneas. Beyond refractive surgery eyes, oblate scleral lens designs are also valuable in peripheral ectasia, advanced keratoconus, and high myopia, and cases where smaller diameter lenses are needed. So in summary, oblate scleral lenses are an important tool not only when managing the oblate corneas, but also for improving outcomes in complex prolate eyes. So the clinical fitting pearls for oblate cornea, fitting lenses on oblate corneas. When fitting scleral lenses on oblate corneas, our approach has to be slightly different from the usual prolate cases. So we generally start with the lowest sagittal height because if you are going to use a standard prolate design, it often leads to excessive central clearance. Instead, a reverse geometry or oblate design are more effective since they allow us to wall the corneal apex without creating an unnecessary deep fluid reservoir elsewhere. Lens diameter selection, it plays a vital role. Larger diameters around 16 to 18 millimeters helps us to distribute lens weight more evenly and improve the centration. But in patients with small apertures, a mid-sized design is often more considered practical. And another key point is limbal clearance. Our target is about 80 to 100 microns of clearance consistently around the limbus. And this protects the delicate limbal stem cells. And again, oblate or reverse geometry profiles are particularly helpful in achieving this without causing the limbal touch. Centration, it's very important. It is also a challenge because the oblate corneas, they tend to decenter the lens inferior temporally. So to address this, we often rely on a toric or a quadrant-specific haptic to stabilize the fit. But while doing so, we must be carefully checking for any compression or impingement at the landing zone. So overall, the fitting goals are very clear: adequate vault, good centration, minimal fogging, and reduced higher order aberrations. So that's going to ultimately give the patient both comfort and functional vision. So we had a discussion. We have discussed the key pearls for fitting the scleral lenses in oblate corneas. Now let's move on to some real-life case examples to see how these principles translate into the clinical practice. This is a very interesting and challenging case. The patient had a radial keratotomy followed by LASIK and then later developed post-LASIK ectasia. As you can imagine, the cornea was highly irregular and conventional lenses were not at all an option. In this case, we successfully fitted a scleral lens which provided both visual rehabilitation and protection for the fragile corneal surface. So this is the case of 44-year-old male who presented to our hospital with visual complaints. His main concerns were decreased vision and significant glare at night with his current glasses, symptoms he has been experiences for the past 1 year. He reported particular difficulty while driving at night due to the glare and ghosting of images. And his profession, he works as a software professional with an average screen time of about 6 to 8 hours per day. And also he complained of eye strain and frequent headaches while using the spectacles. On probing his ocular history, he revealed that he had undergone bilateral radial keratotomy in 1994, followed by bilateral LASIK in 2000, which was done elsewhere. And he has also he has also come to us seeking a better and more reliable option for visual management, as his current glasses no longer was meeting his visual demands. So on examination, his best corrected visual acuity with the glasses was 6/12 with Snellen acuity in the right eye and 6/18 in the left eye. This remained consistent throughout all the follow-up visits which he had come on an yearly basis. However, despite maintaining this moderate visual acuity, the patient reported persistent visual complaints, mainly glare and ghosting of images, which were particularly troublesome for him during the nighttime activities, especially when he was driving. On slit lamp examination, you could see the cornea of both eyes showed multiple radial keratotomy incisions extending from the mid-periphery to the towards the central cornea. And these incisions were well healed, but the presence were clearly evident across the corneal surface. In the left eye, we noted a corneal scar, which is situated close to the visual axis. And this scar was irregular and it's given proximity to the central pupillary area. It was likely causing significant light scatter for him, contributing to the patient's symptom of glare and ghosting in the left eye more than that of the right eye. On further ancillary testing, the pupils were found to be round and irregular and they reacted normally to light. The extraocular muscle movements were full, free, and painless in all the directions of gaze. The intraocular pressure measurement was also done, which were within the normal limits. On fundus examination, myopic retinal changes were noted. So these are all the corneal topography reports of both the eyes taken across 3 visits. What is interesting in this case is the progressive increase in the keratometry readings, which you can see from the visit 1 to visit 3, which is suggestive of progressive corneal change. And also the topographer has allowed us to objectively document these changes, highlighting the instability of the cornea in this case, despite his previous refractive surgeries. So this is the corneal difference map, which is an excellent tool to quantify the amount of progression over the time. So by comparing the baseline visit with the most recent visit, we can clearly appreciate the significant steepening of the cornea. And in the right eye, the progression is about +6 diopters noted from the baseline, while in the left eye, it was close to around +4 diopters. So this marked increase in the corneal power over a relatively short follow period confirms that the patient is experiencing an active corneal ectatic progression. So the difference map, it not only just highlights the magnitude of change, but also provides strong objective evidence to correlate with the patient's visual symptoms and the topographic patterns we saw earlier. Given the progressive nature of the corneal condition, this patient was referred to the contact lens clinic for a specialized lens trial. The patient was highly motivated and he expressed a strong preference to explore the best possible visual correction option as he doesn't want to face further visual challenges. So after a detailed discussion about the option of scleral lenses were presented, with the patient's consent, the trial was initiated. So the initial assessment began by carefully evaluating the corneal contour of the eye in order to select the appropriate sagittal height of the lens. So since the eyes were both proptotic due to myopia and ectatic, a higher sagittal height was chosen for each eye. So this ensured that there was sufficient clearance between the lens and the cornea, providing both safety and comfort for the patient. So what we have done for this patient, a higher sagittal height with a larger diameter scleral lens was selected from the Boston side scleral lens set, PROS lenses, to ensure an optimal relationship with the surgically altered cornea. Because of the presence of the scleral asymmetry, a toric haptic design was chosen to provide stable alignment and minimize the lens rotation. As you can see the parameters here. The initial diagnostic lens was inserted and about 20 minutes settling period was given and over-refraction was performed. With the scleral lens in place, the patient's visual acuity improved from 612 to 66 in the right eye and 618 to 66 in the left eye respectively. And patient also reported excellent comfort, a remarkable improvement in the vision. He was given adaptation in indoor and outdoor, and he has noted ghosting and glare was significantly reduced, almost absent with the scleral lenses, he said. Looking at the scleral lens fit, so how do we start the scleral lens fit assessment? So usually it's performed in this order, like assessing the central vault, followed by the mid-peripheral vault and limbal vault, and finally the haptic alignment of the lens. So as a part of our standard clinical protocol, we always make sure to monitor the scleral lens fit very closely. So before we put the lens on, a careful slit lamp examination is very, very important. Then we need to look for any lid abnormalities, corneal staining from the surgical marks, and any conjunctival problems like pingula or pterygium is present that might interfere with the lens fitting, and it helps in determining the lens diameter as well. So because these are surgically altered corneas, we always keep an eye on the corneal thickness and intraocular pressure. So we check it before the lens wear and after the lens removal because hypoxia-related swelling can creep in. Ideally, the edema percentage should always remain well within the safety limit, and the diagnostic trial lens will be is selected, and the lens should be always filled with the saline that has fluorescent mixed in, because this is going to be one amongst the way to accurately judge the vault, especially the central clearance. And then the lens fit assessment, it is carried on this way, day 1, day 2, likewise. So on day 1, the lens is assessed for about 3 hours. And on day 2, we extend it to 6 hours. This helps us to understand not just how the lens sits initially, but also how the eye responds over time. So next will be the vision check after 30 minutes after the lens insertion. So always keep in mind, it's not just about measuring the visual quantity, it is like checking vision in terms of quality as well. So I usually ask my patients, do they notice any ghosting or doubling of letters? If they say yes, it tells me we might need to tweak the lens optics, maybe with different eccentricities. And also if the pinhole vision show a big improvement, then that's a very good clue that the vision can still be optimized further with optical changes. So after the 3 and 6 hours of lens fit assessment, make sure we recheck the corneal thickness again and intraocular pressure after the lens removal, along with the ocular surface straining to rule out any hypoxic signs such as microcystic corneal edema is present or not. So that way we know for sure the scleral lens is not causing any physiological stress on the eye. So moving on to this case, the scleral assessment was done for this patient, and this was done after 6 hours of lens wear on day 2. In the right eye, we found a reduced central vault, but with a good limbal vault and well-aligned haptics. In the left eye, we can see reduced central vault, and we noticed a haptic edge lift at the 3 and 9 o'clock position. So this edge lift was particularly important because what happened, the patient started to give report fogging of vision after about 3 hours of lens wear, which could be because of the turbidity of the fluid reservoir. And on closer evaluation, as I told before, this was linked to fluid reservoir turbidity, which was most likely caused by that local edge lift, allowing the tear exchange and the debris entry beneath the lenses. So based on these findings, the final lens was modified by steepening the haptic for the edge lift in the left eye, and rest all the final lenses, other modifications like the central vault, increase in central vault was made. And the final lens was dispensed accordingly by providing an optimal fit and visual quality. So this patient, he came for 1 month follow-up visit after wearing the lenses. So what happened? He was very happy with both eyes with the vision and overall comfort. His average wear time was about 8 to 10 hours a day with proper breaks of around 1 hour. The only challenge he reported was he had difficulty while removing the lens from the left eye independently. On examination, the right eye was showing on optimal fit with no signs of edge lift or conjunctival impingement, whereas in the left eye, we observed an impingement at the 3 and 9 o'clock position. Actually, to address this, the haptic was steepened in the edge lift zone during the initial trials, but further again, because of this edge lift, if in case we are going to again steepen the fit, it's going to really cause conjunctival impingement and make the patient's life miserable in removing the lenses often. So what we have done was we have introduced the radial channels which was very much helpful because they reduced the suction and it has allowed easier tear exchange and make the lens removal much more comfortable for the patient. So let's see what radial channels are actually. So the radial channels are a unique lens modification which is designed to prevent the suction. They are about 200 microns deep and it's placed in the haptic surface of the lens, as you can see here. By doing this, they can help maintain an expanded oxygenated precorneal tear film, and it can promote the tear exchange, especially in sealed lenses. Most importantly, they make it much easier for patients to release the suction and remove the lens comfortably. So while placing the lens order, it's always essential to specify both the location, the width of the channel to achieve the best outcome. So the patient reported being very happy and comfortable both in terms of vision and overall lens comfort. And his average wearing time was close to around 8 to 10 hours per day with adequate lens breaks of about 1 hour in between. Importantly, there were no challenges faced in lens application or removal, which further added to the ease of use and satisfaction. And because of the radial channels, we were unable to see any impingement or edge lift there. The patient was quite happy. And to summarize, when we are dealing with this compromised corneas, we have to be extra cautious with our scleral lens fitting approach. The first principle is to fit with a reduced vault because excessive clearance may limit the oxygen transmission and worsen the hypoxia. So always good choice using a high decay material as it allows maximum oxygen availability to the cornea. In some cases, we can consider fenestrations or channels. These modifications definitely can improve the tear exchange and help reduce the risk of suction. We also should advise the patients to limit their initial wearing time instead of starting with long hours. It's safer to begin, say, 4 hours per day, gradually increase under the supervision. And finally, very close monitoring is mandatory. And regular follow-up visits which allows us to carefully assess how the lens is interacting with the compromised cornea and to make timely adjustments if in case it's required. So this vigilance is key to ensure both comfort and safety for the patient. So that's all about case one. I think we'll move on to the case two. So he's actually a 40-year-old male, a businessman who presented to our tertiary eye care center. His main complaints were double vision for the past 1.5 years and a blurring of vision that he has been experiencing nearly close to around 32 years. In addition, he also reported noting multiple floaters in both eyes with with the right eye being more affected than that of the left eye. On reviewing his past ocular history, we found that he had undergone LASIK surgery about 23 years ago for a high myopic refractive error, approximately minus 12 diopters in both the eyes. And later he developed macular edema in the right eye, for which he received multiple intravitreal injections and retinal laser treatment around 10 years ago. And followed this, the patient also started to develop a squint. Additionally, he had a strong positive family history of myopia in his mother and siblings, and systemic history of hypertension, for which he was taking the medications. On presentation, his best corrected visual acuity with the glasses were 6/18 in the right eye and 6/9 with the left eye. And these findings were found to be consistent with both objective and subjective refraction values. On cover test, the patient was found to have a right convergence squint with an alternating pattern. The extraocular muscles movements were full, free, and painless. And suppression was noted in the right eye for both distance and near. And for near fixation and unforced diplopia was observed. Prism bar cover test was done, which measured 20 prism base out for the distance and 14 prism base out for the near. So on anterior segment evaluation, LASIK flaps were noted in both the eyes. Otherwise, the anterior segment findings were within normal limits. The intraocular pressure assessment and color vision testing were performed and both were found to be within normal limits. On fundus examination, both eyes showed a myopic fundus. In the right eye, laser lattice degenerations were noted with a dull foveal reflex, and the left eye, he had a normal foveal reflex. Both eyes showed tessellated fundi, and in the right eye, a possibility of posterior staphyloma was also noted. So corneal tomography was performed and it revealed central corneal flattening, as you can see here, which is more pronounced in the right eye when compared to that of the left eye. So looking at the anterior elevation map in the right top corner, we can clearly appreciate the central flattening of the cornea, along with an elevated points in the mid-periphery. And these changes are due to the central ablation performed during the LASIK. Overall, these findings clearly define the oblate shape of the cornea in both eyes. On pachymetry, the corneal thickness was found to be around 406 microns in the right eye and 446 microns in the left eye. Further evaluation of the epithelial profile, it showed that the epithelial thickness measured 53 microns in the right eye and 51 microns in the left eye. And there was no evidence of post-LASIK ectasia. So this patient was referred to our contact lens clinic for further evaluation. As a first step, we performed a corneoscleral profilometry to better understand the ocular surface before initiating the lens trial. Looking at the right eye, the map showed a moderate degree of asymmetry. The sagittal height was slightly higher in both the superior and inferior regions. And the initial sagittal height suggested for a 12 millimeter ring diameter was close to around 2,481 microns. This finding indicates an irregular corneal surface, which is an important consideration because it can influence how the lens aligns and centers. On the other hand, the left eye appeared more symmetric in its profile. However, the overall sagittal height was higher compared to that of the right eye, which was close to around 2,603 microns at 12 millimeter ring diameter. And both eyes had a HVAD of 11.5 millimeter. So this suggests a relatively more elevated scleral shape, which again has implications of lens selection and fitting strategy. So in summary, we have an asymmetric right eye in both with a lower sag height and more symmetric but higher sag height in the left eye. So these details completely were helpful for us to decide the starting point for the lens diameter and sagittal height selection during the fitting process. So based on the suggested lens parameters, we selected the diagnostic set with a sagittal height of 2,600 microns and 2,800 microns for both eyes from the Boston Foundation Scleral lens trial set with a diameter of 16.5 millimeter. So as per our routine clinical protocol, after the lens insertion, we allowed for a settling period for 20 to 30 minutes. The vision check was done and the fit assessment were then carried out. And then approximately, excuse me, 30 minutes after the insertion to ensure a more accurate evaluation. So due to the oblate corneal profile, the overrefraction turned out to be so much surprising, significantly high with the high values of around minus 18 diopters in the right eye and minus 14 diopters in the left eye. So the patient also reported binocular horizontal diplopia along with complaints of distorted or wavy lines, which could be contributory due to the macular edema as well. So after 6 hours of lens wear, we re-evaluated the lens fit. In the right eye, the central vault was close to around 350 microns, but superiorly, the vault was reduced, as you can see in the image over here. And in addition, we have noted areas of limbal and temporal touch along with overall conjunctival impingement. In the left eye, the central vault, which was close to around 300 microns, had reduced to nearly 200 microns after settling. Similar to the right eye, nasal and limbal temporal touch was noted, accompanied by overall conjunctival impingement. And in the central vault, you can see a superior touch as well, just like the right eye. So these findings clearly it has demonstrated the effect of lens settling over time and reinforcing the importance of extended wear assessment to accurately judge the fit and decide on the necessary modifications. So abrameter was done, performed over the trial lenses to evaluate the level of higher order aberration. The results showed a significant increase in the total higher order aberrations, particularly coma in both the eyes, as you can see here. This indicates, although the scleral lenses they provided physical fit and coverage, the induced optical aberrations, especially coma, were contributing to reduction in the overall visual acuity with the right eye being more adversely affected. So the reason for this is an increase in the aberration in the largely related post-LASIK oblate corneal profile. So in such eyes, when a scleral lens is applied, the tear reservoir formed between the oblate cornea and the relatively spherical surface of the lens creates an irregular pathway. So this mismatch usually often results in high level of coma and other higher order aberrations, which can significantly impact the patient's subjective visual experience. And even if the lens appears clinically good fitting. So in this case, because of this high over-refraction value, we designed a reverse geometry lens with a central flattened base curve. So this design is going to definitely reduce the sagittal height, meaning that the lens is going to sit closer to the cornea. As a result, the central wall decreases, which increases the risk of corneal and head sagittal height modifications. Due to the risk of central touch, we have increased the sagittal height according to the flattening of the base curve. And optically, since the cornea is relatively steeper than the lenses, a plus tier lens is created, which has led to a hyperopic shift in over refraction. So to address this, we compensated for the tear lens power through the sagittal height and haptic modifications were done, thereby balancing the lens fit and optical performance. So as you can see in this image, this was a diagnostic trial lens which was fitted in the right eye. And this is the modified lens, which is reverse geometry lens, where we can see reduced touch. The tear film is also uniform. So if you closely look, you will notice a superior touch in both eyes with the diagnostic lens. This indicates an area where the lens is coming into contact with the cornea due to the insufficient fault. Because of this and due to the significantly high over-refraction value observed during the diagnostic fitting, so we decided to put a reverse geometry scleral lens for both the eyes, and we addressed the issue by flattening the central base curve, which helped to neutralize the excessive power by the tear lens. At the same time, we adjusted the sagittal height to create a more uniform, consistent vault across the entire corneal surface. So with these modifications, we achieved a better alignment over the irregular corneal surface and improved overall lens width. As a result, the final lenses in both eyes was reduced to around minus 0.5 diopters, thereby improving the vision from 6/18 to 6/9 in the right eye and 6/6 in the left eye without any ghosting of letters. And also we have made the peripheral haptic zone adjustments to enhance the lens alignment and comfort. And this has ensured a more stable and well-tolerated lens wear experience for the patient. So to objectively demonstrate the improvement in visual quality between the initial trial lens and to the final custom design scleral lenses, we performed abrometry under both the conditions. So as you can see in this comparison, the trial lenses resulted in higher order aberrations, which would have contributed for the visual distortion and glare and the reduced clarity, especially in the low light condition. After switching to the final corrected, we observe a drastic reduction in the higher order aberrations, indicating much more better optical quality. So this reduction, it has happened in both the eyes, and this reduction directly translates to a noticeable improvement in the patient's visual experience, not just in visual acuity, but also in the overall clarity, contrast, and comfort. So this change is not just measurable on paper, it's something the patient can truly feel in their day-to-day vision. So though the patient is happy with the vision clarity, the patient significantly, he has been reporting good visual acuity and quality with the final scleral lenses. However, the residual binocular diplopia persisted due to the non-corneal cause. So to address this, this patient was referred to the binocular vision clinic where they have prescribed the Fresnel prisms. With the prisms in place, the patient was able to fuse the images and demonstrated good binocular function. So the combined approach of scleral lens correction and prism therapy, it has definitely resulted in both optical clarity and functional visual comfort. So he was then called for 1 month follow-up visit. So during the follow-up visit, 1 and 3 months, in terms of outcome, the patient was he was able to wear the scleral lenses comfortably. Say he has started wearing 10 to 12 hours a day without any redness or discomfort. And he reported being able to drive at night, which was his main concern, with confidence, and also felt that his diplopia was significantly reduced with the addition of the Fresnel prisms. And his complaints with the scleral lens has been like excellent. Most importantly, you know what, the patient expressed his own satisfaction in a very touching way. So he started to draft his experience in a letter. After taking his consent, I wanted to share this with my fellow practitioners. So as a practitioner, usually our ultimate goal is always to touch lives by providing the best possible treatment and management for our patients. What moved me most in this case was a heartfelt note from the patient who wrote that the scleral lenses have given a whole meaning to my life. This is what he has quoted in his letter. And also, he said after 2 decades, he can finally see better than ever before with a smile. And also, in his own words, he said, after 20 years, I could finally see life in focus. So what else a practitioner would want? So as a practitioner, these words reminds us that scleral lenses are far more than just a piece of plastic for the patients. It proves that it has the power to create the wonders, to restore the vision, and it has truly changed people's lives. It can happen if it has been customized according to the patient's ocular conditions. So to summarize, with the key take-home messages from this case, first, post-LASIK corneas, they have an oblate cornea. So with the central flattening and mid-peripheral steepening, so this unique profile makes them particularly challenging for a standard scleral lens fitting. So if we attempt to use a conventional scleral lens design, patient often end up with a significant over-refraction, higher order aberrations, which directly compromise the visual quality. So try to choose a reverse geometry scleral lens, which are going to be an excellent solution. So by flattening the central base curve and allowing the better sagittal height control, they provide a more stable fit, enhanced comfort, and improved vision. Fourth, assessing the lens after an extended wear, ideally it's going to be really helpful, particularly after 6 hours. This helps us to detect issues like wall reduction, limbal touch, or edge impingement that might not be visible immediately after the insertion. And finally, for the patients who still struggle with their, say, residual optical quality issues, advanced designs like wavefront guided scleral lenses can significantly reduce aberrations and definitely further can sharpen their vision. In short, I would say the real success in post-LASIK corneas lies in the customization of the lens design combined with careful long-term evaluation. So I thank you all for the patient listening, and that concludes my presentation, and I'll be very happy to take any questions now. Thank you.